You can all tell me what you pay for your health care, your health plans, workers' comp programs, your wellness programs. You can tell me to the penny what you pay to doctors and hospitals in claims dollars. What you can't tell me, however, is what you get in return for those claims dollars. Currently, we try to measure that return for the claims dollars in terms of quality. And quality focuses on what a doctor did or didn't do. And it's a qualitative measure, not a quantitative one. Examples of these quality measures are clinical-based evidence guidelines. Or did the doctor comply with the HEDIS checklist? That's just a series of things that is used by a lot of insurance companies and Medicare Advantage plans to make sure that the doctor is doing what they should. For example, if a female patient over a certain age goes to their doctor, did the doctor make sure she had a recent mammogram? There are also other quality measures such as patient experience. Did you like your doctor? And that's scored by Press-Ganey measures and CAHPS. Now, the input into the healthcare equation are those claims dollars. What we need to do is have the output of the healthcare equation be in dollars and cents too, so that we can compare the two back and forth and calculate what we're getting in our return on investment. And for that output, we need to measure what really matters, the patient's outcome. Did the patient get better? And if they did, how much did it cost and how long did it take? That's what we're going to talk about today. How to quantify a healthcare outcome, put it in dollars and cents so that the output, the patient's outcome, and the input, those claims dollars, are both in dollars and cents so we can measure them. And we're going to do that across diagnoses, providers, plans, programs, and treatment patterns. But it could have put a quantitative outcome on each one. Now, there are two ways to do it depending upon the data set that you have available to you. We always start with the medical and pharmacy claims. And then if we have another data set, the medical absence costs caused by those claims dollars, then we can quantify the outcome based upon the risk-adjusted total cost, claims, and absence to get and keep an employee at work. A lot of times we're not going to have those absence costs to match up against the claims. In that case, we'll quantify the outcome based upon the risk-adjusted claims per healthy day. Now, once you can quantify a healthcare outcome, you can put a dollar and cent value on it. You can do all kinds of things you couldn't do before to drive down your costs while improving the care. This slide here just shows some of them. Beginning in the upper left corner, now you can rank things based upon the outcomes that they achieve. Who's the best primary care doctor or PCP in your network for treating diabetes? Who's the best surgeon for knees? Are you getting better patient outcomes by sending your back patients to chiropractors or physical therapists? You all will have case managers taking care of your high cost and chronically ill folks. Who's the best case manager? What case manager gets the best patient outcomes overall and for each diagnosis? In your workers' comp programs, who's the best workers' comp adjuster? Going over here to the top left, now you can optimize your network. Now, depending upon who you are, you'll have more or less success doing this. So if you're a self-insured employer and you've engaged an insurance company called a TPA or third-party administrator to give you the network of doctors and hospitals for your folks to go to, you're not going to be able to go to that TPA and tell them to include or exclude certain doctors from the network, so you just have the very best ones. But if you're an insurance company like Blue Cross or a TPA, you can do that. You can optimize your network for each diagnosis to include the very best doctors, or more likely exclude the very worst ones, provided that your contracts with your health systems allow you to do that. But even as an employer, there's still a number of things you can do to optimize your network. For example, you can stratify it. When you stratify a network, you say you can go to anyone in the network you want to, but if you go to these very best doctors that I know will cost less and get you better care, I'll eliminate or I'll decrease your copays and your out-of-pocket costs. If you have a high deductible health plan with health savings accounts, you can pay folks to go to the better doctors by contributing to their HSA when they do so. Now going down here to the bottom left, now we can direct and steer care. And here's a fundamental difference between health plans and workers' comp. In health plans, you can only tell folks who the better doctors are. They can still go to whoever they want to go to. Not so in workers' comp. In 34 states, including Texas, an employer can direct care. They can tell the injured worker what doctor they have to go to. But still in the health plan world, you can still do a lot to steer care. You have those case managers working with your chronically ill folks and your high-cost claimants. They'll be looking for guidance to those case managers on who to go to. You can give lists of those best doctors for each particular condition, the best doctors for diabetes, the best surgeons for knees, to those case managers so they can guide your folks to the better doctors. You can also do this through the physicians, especially the primary care physicians. When they have to make referrals to specialists and surgeons, who's the best specialist or surgeon to make that referral to? And this is particularly powerful when an employer has an employee clinic where all their employees are going. Now the PCP staffing that employer clinic can refer those employees to the best doctors. And of course, you can also do it through the patients themselves, giving them a find a provider tool where they can look up the best doctors for what they need. Going over to the middle of the graph, you all have wellness programs. You've probably been promised fantastic returns on investments on those wellness programs. Are you getting them? Do you actually know what the outcome of those wellness programs are? We're going to talk about how you can quantify the results of a wellness program so you know what you're saving. You can compare that to what you're paying, and you can calculate your real return on investment. And finally, over there in the lower right corner, now you'll have reporting transparency that you didn't have before. Instead of looking at one claim at a time, you can look at all the claims over the entire continuum of care, claims and absence, based upon the outcomes that those costs achieve for you. There have been a number of articles written on these analytics. These are just some of them. The magazine of the Self-Insurance Institute of America, their national magazine, published an article, How to Decrease Your Health Plan Costs. PRIMA's national magazine published a case study on the city of Fort Worth, on how the city of Fort Worth used these analytics to drive down their costs by 23%. And D Magazine wrote another article on how the city of Fort Worth was using these analytics entitled, Doing the Impossible, Better Care at Lower Costs. So what we're going to do is we're going to combine into a single dollar value both cost and quality. And as I said, there's two ways to doing that depending on the data you have available to you. We'll always start with the medical and pharmacy claims as a cost. Then when we have the absence costs, either from the HR records or for workers' comp insurance companies, the indemnity payments paid to injured workers, we'll combine those claims costs and the absence costs based upon the total cost to get and keep an employee at work. And those absence costs do double duty. They straddle both cost and quality. They're a real cost, but they're also an indication of the effectiveness of the care. Because the quicker you could get the employee better and back to work, the more effective that care was. A lot of times you're not going to have the absence cost to match up against the claims dollars. You'll just have the claims. In that case, we use the claims as the numerator, and then we have a fraction. The numerator is the claims for a diagnosis over the course of the year, say diabetes or whatever it is. And the denominator is the number of healthy days during that year. And healthy days are just the 365 days in a year minus the unhealthy days. And unhealthy days are days that you spend in the healthcare system. You're in the hospital, you're visiting the doctor, or you're at home, but you're unable to function normally. And the algorithms can see all that in the claims. Take the claims, the numerator, divide it by the number of healthy days, the denominator, and that's your claims per healthy day. So who can use these solutions, and which solutions should they use? Well, for the claims plus absence cost solution, the solution that quantifies the outcome based upon the risk-adjusted total cost to get and keep an employee at work, if you're a self-insured employer, that's what you would use, both for your health plan and your workers' comp. Because in your HR records are those medically related absences. And we'll talk about how you can find those in here in a second. If you're a workers' comp insurance company or TPA, you'd also use this one. Now, you're not going to have the employer's HR records, but you have something almost as good, and that's the indemnity payments paid to an injured employee while they're out. If you don't have those absence costs, well, then you just use the claims per healthy day. So if you're an insurance company like a Blue Cross, if you're a Medicare Advantage plan, if you're a large multi-employer plan, an example would be the Texas Teacher Retirement System. It provides the health insurance for a lot of school districts around the country. They have the claims, but they don't have those absence records from the school districts. If you're an ACO or a provider group taking on risk, you'd also use this. And if you're looking at the dependents under an employer health plan, you'd use this one too, because you're not going to have any absence costs to match up against those dependents. I don't have to tell you that healthcare is the tapeworm eating the US economy from the inside out. That's a paraphrase from Warren Buffett. Last year, we spent $3.8 trillion on healthcare, 18% of our GDP, or $12,000 per man, woman, and child. So where do we all get our health insurance? About 160 million of us get it through an employer, 90 million through employer self-insured plans, 70 million through employer fully insured plans. We'll talk about the difference between the two here in a second. 60 million folks get their health insurance through Medicare, either traditional fee-for-service Medicare or Medicare Advantage plans. 12 million folks get their health insurance through the Affordable Care Act marketplace. And even though we've had the Affordable Care Act now for a decade, there are still 29 million folks that don't have any health insurance at all. So what's the difference between an employer being fully insured and self-insured? And why does that matter for today's analytics? Well, if you're fully insured, you engage an insurance company, you pay them a premium every month. And out of that premium, the insurance company pays all the claims for your employees and their dependents to the hospitals and doctors. The insurance company will pay its overhead, and hopefully it has something left over as a profit. And the insurance company is the one at risk for those claims. If a claim exceeds those premiums, the insurance company still has to pay the claim. They're the ones at risk. Now, if you're self-insured, you're still going to engage a third-party administrator called a TPA, and they'll provide the network of all the doctors and hospitals for your folks to go to. And they'll process the claims for you, but the employer is the one at risk for those claims. The employer is the one paying the claims. So why would an employer want to self-insure? Well, it can be cheaper and more flexible in buying insurance. When you're buying insurance, you're paying that monthly premium. That, in effect, prepays the claims. And those premiums can be subject to state premium taxes as well. When you're a self-insured employer, you pay the claims when they become due, 60 days after the employee visits the doctor. And you can also protect yourself against catastrophic claims by buying stop-loss insurance. So if a particular claim or all the claims in general exceed that stop-loss amount, well, the stop-loss insurance company will pay the excess. It's also more flexible when you're self-insured. When you're buying insurance, you're buying a standard plan from the insurance company. You're getting what they're selling. And you're going to be subject to the state insurance regulations in every state where you operate if you have multiple locations. If you're self-insured, you get to design your own plan to fit your particular needs, and you're only subject to the federal ERISA laws. So one law as opposed to many. But the most important thing for today's discussion is that if you're self-insured, you own that claims data, those medical and pharmacy claims that you're paid. You own them. If you're fully insured, you don't own them. The insurance company owns them. And those claims are the basic fuel that we're going to run through the algorithms to quantify a healthcare outcome. You have to have those claims or you can't run the analytics. Brokers will start talking to employers about being self-insured at around 200 employees. But you're going to need a bit more employees because you need more data for these analytics. But there are ways even smaller self-insured employers can make themselves bigger, both horizontally and vertically. Horizontally, you'll have probably multiple employers in the same area. You can pool your data with all the other self-insured employers because their employees are probably going to the same doctors and hospitals that your employees go to. You can also make the data larger vertically. When you start with these analytics, in the beginning, you're going to load 3 to 5 years of data into the algorithm so you can hit the ground running. Now, instead of adding in 3 to 5 years at the beginning, add 5, 6, 7, or 8 and get a bigger data set on which to run the analytics. So as I said, these analytics work on health plans, workers' comp programs, wellness programs. The fundamental difference between health plans and workers' comp is that the potential savings of the pie of potential savings is much bigger in health plans because we're dealing with much bigger dollars. But the relative slice of that potential savings that you'll be able to capture is going to be bigger in workers' comp. Why? Because in workers' comp, you can direct care. You can tell that injured worker what doctor they need to go to, what surgeon they need to go to. In health plans, you can only steer people. You can suggest to them who they can go to. They can still go to whoever they want. But there are all kinds of ways to do that. If you're an insurance company, well, you can select the doctors in the network, or at least have a narrow network within all the broader network where the folks know that these are the better doctors. If you're an employer, you can steer folks through the case managers. As I said, those chronically ill folks are going to be looking to the case managers for guidance. Who should they go to? You can do it through the physicians when they make referrals to specialists and surgeons. Who should they refer to, especially those PCPs staffing your employer clinics? And finally, you always have the find a provider tool that the patients themselves can look up who the best doctors are. So let's get into a little bit of the details. The first solution, the claims plus absence cost solution. We combine all the medical and pharmacy claims with all the medical absence costs to get and keep an employee at work. And those absence costs, as I said, they do double duty. They straddle both cost and quality because the quicker you can get an employee better and back to work, the more effective that care has been. And for a lot of different diagnoses, backs in particular, those absence costs are going to be multiple times the claims costs. And then what you do is you just quantify the outcome based upon the risk-adjusted total cost, claims, and absence to get and keep the employee at work. If you don't have the absence costs, you just have the claims, you're an insurance company, you're looking at the dependents under an employer's health plan, you use the claims per healthy day. Claims per healthy day is a fraction. The numerator of that fraction are the claims during the year for the patient for a particular diagnosis, diabetes. The denominator is just the number of healthy days that patient had. So if they had 20 unhealthy days during the year, then the number of healthy days would be 365 minus 20, or 345 healthy days. And you divide the numerator by the denominator, and you get the claims per healthy day. Unhealthy days are days spent in the healthcare system. You're at the doctor, you're in the hospital, or you're just at home, but you can't function. And the algorithms can see all that in the claims data. One thing that is critical when you're quantifying healthcare outcomes is to risk adjust the data. Let me give you an example. Say you have 2 employees, identical back injuries. First employee, 20 years old, runs marathons on the weekend. Second employee is 60 years old, obese, diabetic, and works in a cubicle all day. We know it's going to cost more and take longer to get that senior citizen better than it will the younger person, even though they have identical injuries. So we have to adjust for that and level the playing field. So we assign each person a risk score. We look through the claims and we decide, is this person healthier than normal, sicker than normal, and we assign them a score. There are a number of risk scoring systems out there. There are quite a few, actually. A good one for an employer to use is called CDPS. It was designed by the University of California, San Diego. And the reason that it's good for an employer to use is that it's used by a lot of Medicaid programs around the country. So it's demographically appropriate for a working age population. It's also open source and free. So you know what you're getting. A lot of these risk scoring systems are a bit of a black box. You don't know why the person is scored the way they are. CDPS is all open source. You know why a person's scored the way they are. And it'll look at the person's age, gender, their comorbidities. You can see in the claims, are they diabetic? And their prescription drugs they're taking. You see a prescription for insulin, well, you know they're a diabetic. Now, if you're looking at a Medicare Advantage plan, you'll use a different risk scoring system called HCC that's used by Medicare, because that's for retired folks. So you want your risk scoring system to match up demographically with the population that you're looking at. And then you can overlay over these risk scoring systems social determinants of health. What are social determinants of health? Well, it just basically is the concept that a person's social circumstances will affect their health and their health care. There are many of them. I'll give you two examples. Income and zip code. If you've got an employee that doesn't make much money, a low wage earner, and you have a high deductible health plan, well, that employee might want to defer care because they're going to have to pay for the entire amount of their health care until they reach that high deductible amount. So if they have something that's relatively minor, they might not go to the doctor. And that thing that was relatively minor festers into something that becomes very major and blasts through that high deductible health care, high deductible amount. Another one is zip codes. In America, we have what are called food deserts, places where you can't buy healthy food. If you can't buy unhealthy food, well, you're going to buy unhealthy food and fast food. If you buy fast food, well, you're going to get obese. If you get obese, you might get diabetes. And those things are very expensive because not only do you have to treat the employee for obesity and diabetes, but those are comorbidities that make everything else more expensive. So if an employee breaks their leg and they have diabetes, well, they're probably going to cost more than an employee that breaks their leg that doesn't. Another thing you have to do is you have to sort things in the appropriate categories, get them in the proper bucket so you're comparing apples to apples. You can't compare a primary care doctor or PCP to a surgeon. So you have to sort things out. And then you have to allocate to each doctor all the costs that that doctor is responsible for. Give you another example. Got two employees with back injuries again. First employee goes to their primary care doctor, their PCP. PCP sees them for 15 minutes and refers them on to a surgeon. Second employee goes to their PCP, and PCP doesn't refer them to a surgeon. They have the employee come back multiple times to rehabilitate the employee without the cost of the surgery. If we just look at the PCP's direct costs, that first PCP is going to look much better. They just saw the employee one time for 15 minutes. But if we look at all the costs that doctor is responsible for, including the downstream costs from the referrals, the second PCP is probably going to look much better. Even though they saw the employee several times, they don't have the surgeon's costs included in their calculations. Because if you're a PCP or any doctor, you're responsible for all the costs from yourself and from your referrals, because you're the one making those referrals. So if a PCP refers a patient to a bad surgeon or a bad specialist, that PCP has done a bad job. And this allows us to evaluate the referral patterns. We can see where doctors are referring. And oftentimes what happens is a PCP, they're doing a fine job themselves. They're just referring to the wrong specialist or the wrong surgeon. And then that's easy to correct. You can sit down with them and show them, here's what you're doing, and here's what you should be doing. Here's who you should be referring to. This slide is going to go through the layers of algorithms needed to quantify a healthcare outcome. We begin in the upper left with the medical and pharmacy claims. And then we add as much data that we can. The more data you can add in, the more robust your results. But those medical and pharmacy claims, they're the basic fuel for our analytics. So continuing on into the left, we have to identify the root diagnosis. What's the primary thing we're concerned with? Are we looking at a patient with diabetes, asthma, a broken leg? We identify that root diagnosis. And there are two categories of root diagnosis. Chronic conditions, things that never go away, asthma, diabetes, and episodic ones. They have a beginning and an end. You break your leg. And the solutions look at them slightly differently. For the claims plus absence cost solution, for chronic conditions, we look at it in a 1-year increment. For the episodic ones, we look at it from the beginning of the episode until the end. For the claims per healthy day solution, we look at everything in 1-year increments. Once we identify that root diagnosis, the algorithms sift back through the claims and accumulate all the medical and pharmacy claims related to that diagnosis. So if we're looking at diabetes and the person breaks their leg during the year, we're not going to include the claims from the broken leg with the diabetes calculation. Next, we have to risk score. As I said, we have to risk score everything to level the playing field. So we'll give the patient a risk score, a normalized risk score. Under the risk scoring system, 1 is a person of normal health, average health. A score below 1 is healthier than normal. The lower the score, the healthier. And a score above 1 is sicker than normal. The higher the score, the sicker. And then we just take all the claims dollars that we've accumulated and divide it by the risk score, and we get our risk-adjusted claims dollars. That's the same for both calculations, both the claims plus healthy day, claims per healthy day, and the claims plus absence cost solution. Now the two solutions diverge. Let's look at the green arrow first for the claims plus absence cost solution. We've got the claims. Now we take the dates of those claims and we juxtapose those against the employer's HR records, the time and attendance records, and we spot the medical absences related to those claims. Then we value those absences at either the employee's actual rate of pay or a normalized rate. As I said, if you're a workers' comp insurance company or TPA, you're not going to have the employer's HR records, but you have something nearly as good. You have the indemnity payments paid to the injured worker while they're out, and you can substitute those. So once we get the absence costs, now we divide it by the risk score, and we get our risk-adjusted absence costs, and add those to the risk-adjusted claims to get the total cost of care. Now let's go back up and follow the blue arrow down for the claims per healthy day solution. The risk-adjusted claims is the numerator in our claims per healthy day solution. Now we have to get the denominator, the number of healthy days. So the algorithm sift back through the claims, and they spot the unhealthy days. For example, if we're looking at diabetes, we find the days that the person was unhealthy, in the hospital, visiting the doctor, at home, but unable to function normally, that they were unhealthy. And then we risk adjust those days. So for example, if the algorithm spot 20 unhealthy days for a diabetes patient, and they have a risk score of 2, well, their risk adjusted number of healthy days are 10, 20 divided by 2. Subtract the 10 from 365, and they have 355 healthy days during the year. That's our denominator. Now, there's one more thing you can do with this solution to really separate the good doctors from the bad doctors, because it's more than anything else, we're concerned about quality and getting folks healthy. It's called the quality of life adjustment. So if we're looking at a group of primary care doctors taking care of diabetic patients, they'll have an average number of unhealthy days for the group, right at the 50th percentile. Any doctor that has a risk-adjusted number of unhealthy days above that average, you can take the excess days above the average, multiply it by the group's average claims per unhealthy day, and add that back to the numerator. And the reason you do that is it really gives you a separation between the doctors doing a good job and the doctors that aren't doing a good job. Now we come back and both solutions converge again, and we have to allocate out the costs and the healthy days to the doctors. And we allocate to each doctor all the costs that doctor is responsible for. Not only all their direct costs, but all the costs from their downstream referrals too. And if you've got a primary care doctor that referred a patient on to a surgeon, well, there'll be some double counting involved in this calculation, because the surgeon's costs are going to be included in the surgeon's calculations, and the surgeon's costs will also be included in the primary care doctor's calculations too, because they made that referral. So you'll have some double counting, but that doesn't matter for ranking purposes. And then we just rank things based upon the outcomes they've achieved, either their claims plus absence costs or the claims per healthy day for each diagnosis, say diabetes, asthma, whatever it is. And of course, the lower the number, the better the job. And you can do this across anything. We've been looking at providers, but you can do it across plans, provider networks, treatment protocols, anything at all. So what's the bottom line from these analytics? Better care at lower costs. 30% of all healthcare costs are due to poor or ineffective care, and the better doctors root out those excess costs. Employer absence costs also go down too. because the better doctors get their patients better quicker, but most importantly of all, now people are getting better care. And you only have to move a few folks to have a significant impact. You've all heard of the Pareto principle, the 80-20 rule. 80% of the effects come from 20% of the causes. It's no different in healthcare, and it's no different in the general economy of the United States or in your particular health plans. There's just a few folks that account for most of the costs, and if you can get to them and get them to the right doctors or in the right treatment patterns, then you'll have a real outsized impact. In the US economy, 1% of the population accounts for 22% of the costs. 5% of the population, half. In keeping with that 80-20 rule, 20% of the population drives 81% of our healthcare costs. And during the course of the year, 15% of the population doesn't have any healthcare costs at all. Now let me give you some real life examples of how these analytics work. And these are real examples, real data. I've blinded it so you can't see who it's from. But here we're looking at 14 specialists taking care of back patients. And I've graphed them out based upon their average claims cost per person over the entire continuum of care. From the best one there on the far left, the specialist one at about $1,000 per patient, to the worst one on the far right at about $8,600 per patient. But the claims cost is just half of it. We have to look at those absence costs too, because those absence costs are not only a real cost, but they're also an indication of the quality of the care. So when we add in the average absence cost for each of these doctors, this is what we get. Specialist 2 goes from being second best to second worst. And specialist 9 is doing a better job than we initially thought because they're getting their patients better faster. But if you ask any doctor why they cost more than another doctor, they will always give you the same answer. Because my patients are sicker. And sometimes they're right. So we have to risk adjust the population to level the playing field. So that when we're looking at doctors, we're looking at them based solely upon their performances, not the happenstance of what patients they happen to treat. So when we risk adjust the patients, this is what we get. Now specialist 13 looks a lot better than they looked before because they were taking care of sicker patients who we would expect to cost more and take longer to be better. Specialist 13 would no longer be 13 out of 14. They'd be 10 out of 14 if we re-ranked everybody based upon their total risk-adjusted cost to get and keep someone well. So when we re-rank everybody based upon their total risk-adjusted costs, this is what we get. Specialist 1 is still the best. Specialist 14 is still the worst. But other than specialist 12, the order has completely changed. Green arrows show those folks that moved up. Red arrows show the folks that moved down. Here's another way of looking at it. Here we're looking at 2 surgeons doing knee surgery, Surgeon A and Surgeon B. And we're comparing them against each other and then the group of surgeons doing knee surgery in the network. And we're comparing them against the average for the group, the 50th percentile. So in the upper left in green are their average claims per knee surgery. Surgeon A is much worse than average. Surgeon B is much better than average. So just looking at the claims, you'd pick Surgeon B every time. But those claims costs are not the entire picture. When we look at the orange graph over on the far right, it's their average absence cost per patient. Remember, those absence costs, they straddle cost and quality. They're a real cost, but they're also an indication of the effectiveness of the care. And so Surgeon A is doing much better than average on the absence costs, getting their folks better and back to work. Surgeon B is doing much worse. The bottom graph just combines the two. Both Surgeon A and Surgeon B are better than average, but Surgeon A is the better one. That should be your choice, and you'd never see that if all you looked at was the claims data. We don't live in Lake Wobegon where all the children are above average. Some children are above average, and unfortunately, some children are below average. And it's the same with doctors and healthcare. Healthcare is not a commodity. This quadrant graph illustrates that point. So on this graph, each bubble would be a doctor treating a particular diagnosis, patients with diabetes or asthma. Along the horizontal axis, we've graphed their average claims costs. High claims on the left, low claims on the right. Along the vertical axis, we've graphed their average absence cost per patient. Short absences on the top, long absences on the bottom. Our best doctors are in the upper right quadrant. They have low claims and their patients don't miss very much work at all. Your worst doctors are in the lower left quadrant. They have high claims and their doctors and their patients miss a lot of work. So healthcare is not a commodity. All doctors are not the same. Your better doctors make fewer errors. They perform fewer unnecessary procedures. Their patients have fewer complications and they get their patients better faster. Now let's switch gears a little bit. We've been talking about the claims plus absence cost solution, the cost to get and keep an employee at work. Now let's flip the question around and say, how much does it cost in claims to keep someone healthy, to keep them well? Here are 4 graphs. This is real data, looking at primary care doctors taking care of 4 chronic conditions. The upper left, asthma. To the right is COPD. Bottom left is diabetes, and then gastrointestinal problems. You can see there's quite a disparity, both within the PCPs within each diagnosis treating patients and among the diagnoses themselves. For example, look at asthma in the top left. The orange line is the average for this group, 73 cents per day. That's the average to keep someone with asthma healthy. But the best one, PCP 1 there on the far left, is at 29 cents. The worst one, PCP 10, is at $2.16. And then if you look at the different conditions, the lowest condition is asthma at 73 cents. The highest condition is diabetes at $4.36 average to keep someone with diabetes healthy. Let's talk about behavioral health issues. And behavioral health issues are very expensive because not only do you have to treat that behavioral health issue, whatever it is, but that becomes a comorbidity that makes everything else more expensive too. So as I said, if you break your leg, if you have depression, you're probably going to cost more and take longer to get better than somebody that breaks their leg that doesn't have depression. So here we're looking at the claims per healthy day of people in general and comparing them to folks that have behavioral health issues. So over here on the far left, it costs about $10 in claims to keep the average person healthy during a year, looking at all their claims and all their unhealthy days, about $10 a day. But if you have anxiety or headaches, it's going to double to over $20 a day to keep you healthy. And if you've got alcohol or drug abuse problems, it's going to double again to over $40 per day. Now let's talk about wellness programs. You all have wellness programs. Your vendors have promised you fantastic returns from those wellness programs. You know what you're paying for the wellness program, but do you know what you're getting? These analytics allow you to figure that out to the penny. So in the middle there of the slide are the 3 wellness type programs you might have. On the top are the disease management programs. These are for folks with chronic conditions like diabetes. In the middle are your generic wellness programs, your general weight loss programs, your Fitbit programs. And then on the bottom are your employee assistance programs for folks with behavioral health issues. So going over here to the left, here's the inputs into our algorithm solution. It's going to be the medical and pharmacy claims under your health plans, the absence records from your HR department, and then the vendor data. Who's participating in the program and how much does it cost? We run that through the algorithms, and then the output is going to be how much did the medical and pharmacy claims of the employees participating in that program go down? How much did the absence cost of the employees participating in the program go down? That's your return from the program. Subtract from that what the program cost, and that's your savings. Divide your savings by what the program costs, and that's your ROI, your return on investment, in hard dollars and cents. There's really no other way to do it. A lot of times what you see is in wellness programs, especially wellness programs that are first kicking off, that ROI is not going to be anywhere near what was promised. And there's a reason for that. Say you're looking at a diabetes disease management program. The algorithms sift through all your claims, and they identify 500 employees that have diabetes that should be participating in the program. But only 200 of your employees participate, jump in. And who are those 200 employees? Well, they're the folks with diabetes that are very conscientious about it already. That's why they're the first ones to jump in. They're already doing everything they can to manage their diabetes. So they don't have much room for improvement. What you want to do is you want to get those 300 folks that don't join the program initially to join. If you can get them to join, well, then you might start to approach that promised ROI, because those folks do have a lot of room for improvement. Now let me take you through a little bit of the math, not much. I've given you a handout because it's a little hard to read. We'll go through the math for the claims plus absence cost solution first. Here's a table, and the top of the table tells us we're looking at specialists treating back patients. In the gold there in the middle is the group average. So there were 214 employees in this group with back problems. Their total claims were 480,000. So the average claims per person is 480,000 divided by 214, or $2,200. Now we have to risk adjust that amount. Average risk score for all these 214 folks is 1.197, slightly above 1, which is an average person of average health. So we divide the 2,200 by the risk score, and our average risk adjusted claims cost is $1,800. Now we have to get the absence costs. Total absence cost for these 214 folks was $1,080,000, over twice the claims cost, which is not unusual when you're looking at backs. Average claims cost, average absence cost is $5,000. Divide that by the risk score, and our average risk-adjusted absence cost is $4,200. Add the average claims cost and the average absence cost together, and our average risk-adjusted total cost to get and keep an employee with these back injuries at work was $6,098. They're highlighted in yellow. That's the average, the 50th percentile. Now in the blue and the red and the green, I've listed out all the specialists that saw more than five of these patients. The red line is that group average of $5.98. So if you're above the red line in blue, you're doing better than average. Your average cost is less than $6,098. If you're below the line in red, you're doing worse than average. Your average cost is over $6,098. So what we do is to try to gauge the magnitude of the dollars we're dealing with. An exercise we go through is we say, if we took all the employees going to the below average doctors and moved them up to the average, that red line, not to one of the better doctors, just to the average, how much could we save? Well, there are 7 doctors below that red line that saw 63 folks. And if we move those 63 folks up to that red line, not to the better doctors on top, just to the red line, we would save $242,000 over there on the far right in yellow. That gives you an idea of the magnitude of the dollars you're dealing with, so you can make decisions. In a health plan, are you going to save $242,000? No. You're not going to get everyone going to a below average doctor to move. But then again, those that do move are going to want to move to one of the better doctors on top, not to just the average. This chart just graphs out those 14 doctors. So the orange line is the group average of $6,098. The 7 doctors that are doing worse than average, their columns are on the far right above the orange line. So if you took their 63 patients and moved them down to the orange line, you would save your $242,000. If you moved them to one of the better doctors on the far left, you'd save a lot more. And remember that these are risk-adjusted dollars. We took the dollars and divided them by the risk score so we could compare everything on a level playing field. So the actual savings would be more. Now, if you flip over your handout, we'll go through real quickly the claims per healthy day solution. Here we can tell on the top that we're dealing with cardiac patients, seeing surgeons. In the gold again is the group average. In this data set, there were 889 folks seeing these cardiac surgeons. Total claims was 5.6 million. Means the average claims per person is 5.6 million divided by 889 or $6,300. Now we have to risk adjust that. Average risk score for these 889 folks was 2.975. Remember, 1 is a person of average normal health, below 1 healthier than normal, above 1 sicker. These folks are really sick, and you would expect it. They have cardiac issues and they're seeing cardiac surgeons. So we take the average claims amount of $6,300, divided by the risk score, we get a risk-adjusted claims amount of $2,100. That's the numerator in our calculation. Now we have to get the denominator. The algorithm sift back through the claims and they identify the unhealthy days for all these folks, which were 21,000 or an average per person of 24. Divide the 24 by the risk score and we get the risk-adjusted unhealthy days of 8. Subtract 8 from 365, and the number of healthy days for this group was 358. Divide our risk-adjusted claims amount of $2,100 by our average number of healthy days during the year for these folks, and our average claims per day are $5.98. That's right at the average, the 50th percentile. Now, the same as before, we've listed out, in this case, all the surgeons who saw more than 10 of these patients. The red line is a group average of $5.98. So if you're in blue above the red line, you're better than average. Your claims per healthy day are less than $5.98. If you're below the red line in red, well, then your claims per healthy day are above that average of $5.98. You're doing worse than average. There were 11 surgeons below that red line that saw 416 folks. If we took those 416 patients and moved them up to the red line, not to one of the better doctors, just to the average, we would have saved there on the far right $419,000 and improved the number of healthy days by 1,600. This chart just graphs out these 20 surgeons. Orange line again is the claims per healthy day average of 598. So if we took the 416 folks going to those 11 doctors whose columns are above the red line and move them down to that line, we would save our 420,000 and improve our healthy days by 1,600. So how do you get started with these analytics? Well, you don't begin at zero. You've already got all your historical data. Take 3 to 5 years of your claims data, with or without the absence costs, and model it. Run it through the algorithms, diagnosis by diagnosis, and see what the algorithms tell you. And it'll be just like those tables we just went through. For each diagnosis, how much could you save by moving folks going to below average doctors just to the average? They'll give you an idea of the magnitude of the numbers involved. As I said, in a health plan setting, you're not going to achieve that, but it gives you an idea of what you're dealing with. And the numbers, once you add up all the different diagnoses for everything, they can be shocking. There was one employer had claims costs during the year of $114 million. For certain diagnoses, not all, just certain, if they took their employees that were going to below average doctors and moved them to the average, they would have saved $20 million. And that's not for all the diagnoses. They only did certain diagnoses because they only want to look at what they could influence. For example, traumas. You really can't influence the care of a trauma. You get in a car accident, you're going to the nearest emergency room. You're not going to stop and look up who's the best, what emergency room is ranked best, what doctors rank best. You're just going to the first one available. So they didn't look at traumas and a number of other things, and they would have saved $20 million. And then if you do go forward, well, you hit the ground running on day one. You've already got all the historical data all loaded in, and then you just refresh the data every month or every quarter. Save the best one for last. This is a real example. This was an employer's data up in the Northeast, large employer, and they had a network of surgeons. And they had 2 surgeons, these were orthopedic surgeons, two surgeons, Surgeon A and Surgeon B, that did a lot of their surgeries, high volume surgeons. And we compared Surgeon A and Surgeon B against each other and the group average. And these were orthopedic surgeons that specialized in spine surgery, high volume. We looked at their neck surgeries first, in the upper left there. Here you can see that Surgeon A was doing a great job at neck surgery, and Surgeon B was doing a very bad job compared to the average and each other. So when we went down a few vertebrae on the spine, and we expected to see the same thing, and we were completely wrong. It was just reversed, just going down a few vertebrae. Now Surgeon A was horrible at back surgery, and Surgeon B was pretty good. And this is something you often see in the data. It's not that a doctor is all good or all bad. Just like everybody else, we're good at some things, we're not so good at other things. And these analytics exploit what someone's good at to everyone's advantage. If all this employer did was take the patients going to Surgeon A and Surgeon B and flip them around so that each doctor only did what they were good at, they would have saved $900,000 over a 4-year period. A common theme that comes from people when I explain these analytics to them is that this is so different than what we've looked at before, the way we've always done it. And it reminds me of a quote by Henry Ford. If I'd asked people what they wanted, they would have said faster horses. So that's the presentation. Thank you for listening, and I'd be happy to answer any questions.
Thank you, Scott. Does anyone have any questions in the room? If not, Scott will be here afterwards, and you're welcome to come up.
Thank you.